Sir, yes, a 54-year-old tailor till 5 years back was normal, after which he developed complaints of episodic pallor of fingers and toes for 4 years.
What do you mean by that?
Sir, episodic pallor of fingers and toes can be due to like a Raynaud's phenomenon, sir.
Okay. So, in what is meant by Raynaud's phenomenon?
Raynaud's phenomenon is blanching of the fingers and toes due to cold temperature, or it is due to the pathology involved in the small capillaries, sir. They undergo vasoconstriction due to cold temperature, sir.
So, it is the only color? Pallor is only color?
No, sir. Initially, it changes from red and then goes to white and then blue, sir. Goes for cyanosis, sir. It's also called acrocyanosis.
Okay. So, how many types of Raynaud's phenomenon are there?
Sir, primary Raynaud's phenomenon or secondary Raynaud's phenomenon are there, sir.
Can you tell something about the secondary type? What are the causes?
Sir, secondary Raynaud's phenomenon can be due to connective tissue disorders, sir, like SLE, scleroderma, endocrine abnormalities like pheochromocytoma, acromegaly, then systemic mastocytosis can also cause this kind of picture, sir. Like proliferative neoplasms can cause this kind of picture, sir.
Any neurological problems can present like this?
Neurological Raynaud's, sir.
Carpal tunnel syndrome?
Yes, sir.
Any professions?
Sir, welders can have, sir. Welding.
Those who are using vibratory equipment?
Yes, sir.
Okay. So, this patient is possibly having Raynaud's phenomenon starting at the age of 54.
Yes, sir.
Starting at the age of 50 years. Okay. Yes. Okay, carry on.
Pain in multiple joints for the past 2 years, sir.
What details you want to know about it?
Was the pain involving multiple joints at the same time, or the multiple joints were involved at different times, sir?
Multiple joints are affected in an additive pattern. You start with one or two joints and subsequently most of the joints got involved.
Okay, sir. Then whether it was associated, also there was a swelling and warmth with the joints.
Warmth, they do not know. Minimum swelling was there.
Okay, sir. So it could be a manifestation of a serositis of a joint causing joint effusion can be there, sir. The pain in multiple joints, or it could be just an arthralgia.
What important point will tell you whether it's inflammatory process or only arthralgia? What important complaint can tell you whether it's inflammatory disease or arthralgia alone?
Sir, stiffness of the joints can tell us, sir.
I didn't understand.
Stiffness of the joint, sir. Stiffness of the joint can tell if it's arthritis or arthralgia, sir.
How do you elicit it, that history?
So, early morning stiffness of joints, sir.
That's right. Morning stiffness is the point.
Yes, sir.
This patient had morning stiffness. The next complaint is,
if the pain actually...
No, the patient developed dysphagia for last 1 year.
Yes, sir.
Yes.
Dysphagia, pallor and arthralgia, sir.
No, what all details you want to know about dysphagia?
Dysphagia, whether it's associated with solids and liquids, sir.
Yes, it was.
So, we have to check whether it's due to a neuromuscular junction involvement or muscle involvement of dysphagia, sir.
Okay, fine.
Or any nerve involvement like cranial nerves can also cause dysphagia, sir. Cranial nerve palsies.
If cranial palsy produces dysphagia, what will be the characteristic history?
Sir, 9 and 10th cranial nerve palsy can produce dysphagia, sir.
Okay, carry on.
Patients can have a history of nasal regurgitation associated with the dysphagia, and then
Is it more for solids or liquids?
It is more for solids, sir.
The solid comes through nose, is it?
No, sir, liquid, sir, liquid, sir.
Liquid, okay. Subsequently,
Tightening of skin.
so which
Difficult.
come to your mind?
Sir, dysphagia, episodic pallor, pain, multiple joints, and tightening of skin. So they all point towards the connective tissue disorder, sir.
Which connective tissue disease produces thickening of the skin?
Scleroderma, sir.
System sclerosis. Okay. Carry on.
Difficulty to get up from bed and low chair. A patient lost his job because of fatigue and was unable to.
No. What do you mean by getting up from bed and low chair? What does it mean to you?
Sir, it can be due to fatigue, sir, or it can be due to muscle involvement. Myopathy, which can cause difficulty in getting up from bed and low chair, sir.
Which myopathy?
Proximal myopathy.
Due to what?
Due to inflammation of the muscles, sir.
What do you call it?
Myositis.
So it can be myositis.
Yes, sir.
So far what all things you made up?
Sir, patient has episodic pallor, which can be Raynaud's phenomenon is present, arthralgia, dysphagia, connective tissue disorder, mostly a scleroderma, and myositis is present, sir.
Okay. Past history.
Caring.
Patient job because of fatigue and was unable to perform. Okay. Past history.
Caries, multiple teeth.
So which condition produces caries in medicine wards?
Sir, elderly, anemia, infective endocarditis can produce caries, sir.
Is it?
Diabetes can produce caries, sir.
So tell me some connective tissue disease which has a relation with the teeth.
Sir, systemic sclerosis can cause caries, sir, dental caries, sir.
How?
It will cause periodontitis, sir.
How?
Capillary involvement, capillaries supplying the gums which are affected can lead to vascular insufficiency and then dropping out of teeth, sir.
So what about Sjogren syndrome?
Sjogren's can cause dryness of the mouth, xerostomia can be there, sir.
Can it affect the teeth?
Sjogren's will affect the salivary glands, sir, minor salivary glands, sir.
Does it affect teeth?
Yes, sir. Silodinitis will cause caries, sir.
Saliva is a protective thing for the teeth. The absence of saliva produces early breakdown of teeth.
Yes, sir.
Okay, carry on.
Hypo and hyperpigmented area on the right side of the face.
Yes.
Yes, sir.
Yes.
So, hypo and hyperpigmentation can be there on in systemic sclerosis, sir.
Okay, right.
Salt and pepper pigmentation, that is because of perifollicular hemorrhages, sir.
Yes. Carry on.
Dyspnea on effort, sir.
Yes. In relation to the history you got so far, what will be the mechanism of dyspnea?
Sir, dyspnea can be due to pulmonary artery hypertension, sir, in case of systemic sclerosis, or it can be due to interstitial lung disease, sir, or it can be due to pericarditis in case of systemic sclerosis also, sir.
What about anemia?
Anemia also, sir. Yes, sir. Anemia.
Past history. What do you make out?
Hypothyroid on replacement dose following thyroidectomy, lost 5 kg over a period of 1 year, sir.
What does this indicate to you?
Sir, he was a thyroidectomy was done, and then was on developed the hypothyroid and is on thyroxine, sir. So thyroxine, and he has lost 5 kg over 1 year. So he is responding to thyroxine, sir.
Now, what may be the etiology of this thyroid disease?
Sir, can be a thyroid malignancy for which thyroidectomy was done, sir.
is it likely that in relation to an autoimmune disease, there's some autoimmune problem with the thyroid?
Sir, autoimmune problem with the thyroid can be Hashimoto's thyroiditis can be associated with systemic sclerosis, sir.
What about Graves' disease?
Yes, sir. Graves, yes, sir.
So
Graves.
to prove here that it can be a case of autoimmune disease, no?
Yes, sir. Hypothyroid.
Yes.
On examination, BMI is 16, pallor present, small area of salt and pepper appearance over the temporal area, vitals are normal, sir.
Okay. So how long you will treat hypothyroidism?
Sir, hypothyroidism has to be treated lifelong, sir.
Okay. This is the appearance of the face.
Yes, sir.
First picture shows the blackening and hypopigmentation.
Yes,
And
sir.
second is, I don't know whether you are able to see properly or not. These are the fingers.
Sir, they are short, stubby fingers, sir.
Okay.
Dactylitis kind of, sir.
System examination. What do you make out?
CVS is normal. Respiratory system expansion only 1 centimeter. So it's looking like a restrictive lung disease. GIT is normal. Higher motor function normal. Cranial nerves normal. Motor system normal. Sensory system normal. In motor symptom, neck flexors are weak. Shoulder grade 3. Hips grade 3. Trunk is weak. DTJ is normal, sir.
It is a deep tendon jerks.
Yes, sir.
And sensor system is normal.
Yes, sir.
So what may be the cause for the expansion 1 centimeter?
Sir, it can be a restrictive lung disease, sir. Interstitial lung disease which has gone in for fibrosis. Lung fibrosis, sir.
Is it possible that this patient's chest was not expanding because of tight skin?
Yes, sir. Possible, sir.
Possible. Okay. Motor system, what do you make out?
Sir, in motor system, the neck flexors are weak, sir.
So tell me some situations where neck flexors can be weak. How do you test for neck flexors?
Sir, ask the patient to flex his neck and touch the neck with the chin, sir. Chin to touch the body of the sternum, sir.
Against resistance.
Against resistance, sir.
Resistance. Where do you apply resistance?
Sir, resistance towards in front of the chin, sir.
Not chin, forehead.
Yes, sir. Yes, sir.
Not chin, forehead.
Yes, sir.
Okay, tell me some situations where neck flexors are weak.
Sir, amyotrophic lateral sclerosis, sir. Motor neuron disease.
Very good, very good. What else?
Myasthenia gravis neck flexors can be weak, sir.
Excellent. Yes.
Then inclusion body myositis variants also neck flexors can be weak, sir.
No, polymyositis itself can produce.
Yes, sir.
Okay. Not only inclusion myositis, everything can produce. Okay. What else? Any other?
Sir, then Cushing's can produce, sir, but
No. Any other neurological problem affecting muscles? Running in families in autosomal dominant fashion?
Sir,
Where they cannot lose the grip?
sir, mitochondrial myopathy, sir.
Dystrophia myotonica.
Yes, sir.
Do you get neck muscle weakness in case of intermediate syndrome?
Yes, sir. Delayed organophosphorus poisoning we can get, sir.
Okay, so this patient had weakness of the neck flexors. Okay.
Yes.
Shoulders and hips were grade 3.
Yes, sir.
What do you think about that?
Sir, it could be due to a proximal muscle weakness due to the secondary to the myositis caused due to systemic sclerosis, sir.
What are the usual complaints of patients with the proximal muscle weakness of the shoulders?
Sir, they are not able to reach for an object above their head, sir. They are not able to lift.
Okay. And these patients' trunk muscles are weak. How do you test for trunk muscles?
Sir, ask the patient to get up from a bed, sir.
Okay. Any other?
Against the resistance. Then move sideways in the bed. If we is able to move sideways in the bed while lying down.
Roll, no? As a patient. Okay. So, how do you differentiate between primary and secondary?
Sir, we can do a nail fold capillaroscopy, sir.
How does it help?
Sir, it helps in saying whether it's primary Raynaud's or secondary Raynaud's. In case of secondary Raynaud's, there will be capillary dropouts and neutrophil infiltration, sir.
The primary is usually symmetrical.
Yes, sir.
Secondary is asymmetrical.
Okay,
the disease will be latent secondary, and usually there is associated cause, as you rightly said. It may be drug-induced like ergot, it may be thoracic outlet syndrome, a neurological problem, endocrine problem, occupation-related situation, polycythemia, most common being connective tissue diseases.
Yes, sir.
So, how do you treat Raynaud's phenomenon, basically?
Sir, if it is secondary, we have to treat the cause, sir.
Primary, how do you treat?
Primary.
You protect the skin. So you use mittens, you use gloves, and avoid smoking, avoid coffee, potential vasoconstrictors, and all.
We can use a low dose of vasodilators, sir.
And you can try
low dose of vasodilators, sir.
Calcium blockers, particularly, may be tried. Helioprost is another one.
Yes, sir.
So basically, you protect the patient, keep the environment, and any precipitating cause needs to be corrected.
Yes, sir.
So, what are the causes of proximal muscle weakness?
Sir, proximal myopathy is endocrine, usually endocrine causes, sir. Cushing's, sir. Acromegaly, sir. Hypophosphatemia, hypoparathyroidism, sir. All can cause proximal myopathy, sir. Electrolyte disturbances like hypokalemia can cause proximal myopathy, sir.
Common endocrine disease, one is diabetes,
yes, sir.
Disease, thyrotoxicosis one,
yes, hypertension
is one. Suppose a patient is hypertensive and there is proximal weakness, which disease you would suspect?
Sir, hypertensive and, sir?
And proximal muscle weakness. Other than Cushing syndrome, anything else can you think about?
Sir, pheochromocytoma, sir?
No. And you find that the potassium is low?
Sir, primary hypoaldosteronism, sir.
Cont syndrome?
Sir.
Cont syndrome. So, endocrine disease one. Can you tell some deficiencies producing proximal muscle weakness?
Sir, thyroid, hypo also can cause proximal muscle weakness, sir.
No, any other deficiency in the food?
Sir,
nutritional deficiency.
Sir,
vitamin D, osteomalacia.
Yes, sir.
So, what will be the gait of these patients?
Sir, they'll have an antalgic gait, sir.
Not antalgic gait, no. Tell me different types of gait.
Sir, waddling gait, sir.
Waddling gait, yes, waddling gait. They have waddling gait. Waddling gait. Tell me other causes of proximal muscle weakness other than endocrine causes and nutritional causes. Other causes are?
Sir, dermatomyositis, sir. Connective tissue disorders, sir.
Polymyositis, dermatomyositis. Myositis, basically, yes.
Sir.
What else?
Then channelopathy, sir. Proximal muscle weakness.
Can you tell some muscular dystrophies?
Sir, Duchenne muscular dystrophy, sir.
Okay, and Becker also.
Becker's.
So tell me one neuropathic condition producing proximal weakness, not myopathy, neuropathy.
Neuropathy causing proximal muscle weakness, sir.
That's right.
Sir, myotonic dystrophy, no, sir.
So basically, neuropathy produces distal weakness.
Yes, sir.
Neuropathy producing proximal weakness.
Sir, arsenic lead toxicity, sir.
Arsenic definitely produces neuropathy.
Yes, sir.
Guillain-Barré syndrome.
Yes, sir.
So AIDP and CIDP neurological problem, neuropathic pattern, but proximal muscle weakness is dominant.
Yes, sir.
Similarly, can you tell me one muscle disease where distal weakness is dominant?
Sir, inclusion body myositis, sir.
Any other?
Sir, myotonic dystrophy, sir, type 2.
Okay. So torso weakness, how do you test? What is the difference between basically neuropathy and myopathy? Patients got weakness.
Sir, neuropathy is usually mostly distal. Myopathy is mostly proximal.
Any other difference? Can you make out?
Sir, myopathy can be the cause is usually endocrine or secondary to a connective tissue disorder. Neuropathy is due to heavy metals, toxins.
No. Tell me the common 4 causes for neuropathy. 4 common causes for neuropathy.
Diabetic peripheral neuropathy, sir.
That's right. You are not telling that. You are telling arsenic and one is diabetes. Next one.
Alcohol-induced neuropathy, sir.
Very good. What next?
Sir, B12 deficiency, sir, neuropathy.
Very good. What else? 4th one.
Drug-induced neuropathy, sir.
Infective polyneuritis or Guillain-Barré syndrome.
Yes, sir.
So the 4 common things.
Yes,
so,
sir.
And the difference between neuropathy and myopathy. Myopathy is always symmetrical.
Yes, sir.
Neuropathy can be asymmetrical, can like a mononeuritis multiply.
Yes, sir.
And neuropathy, classically, the reflexes are absent.
Yes, sir.
Myopathy, classically, reflexes are preserved in the end. And when you test for the sensory system, there may be findings in neuropathy. Myopathy, we don't expect any sensory problems.
Yes, sir.
Tell me some types of myositis you know.
Sir, dermatomyositis, polymyositis, inclusion body myositis, immune-mediated necrotizing myositis, sir.
Okay. So, what are the features of inclusion body myositis?
Sir, inclusion body myositis usually affects the quadriceps and finger flexors, sir.
Quadriceps, that's very good. Unlike the other types of myopathies, it is like that. Yes. Any other feature? What's the age group?
Sir, age group it occurs in second decade, sir. Second or third decade, early, sir.
Yes. So this distribution is different.
Yes, sir.
And how do you diagnose it then?
Sir, inclusion body myositis is a diagnosis of exclusion, sir.
Right, very good. So commonly it occurs in elderly people. It can be asymmetrical, and the distribution of the weakness is also different from the other types of myopathies. And
Yes,
this type of disease, it do not respond to steroids.
Yes, sir.
Has it got any connection with any malignancy?
Sir, dermatomyositis, inclusion body myositis, both are associated with malignancies, sir. They can present dermatomyositis, nearly 50% of dermatomyositis can be associated with malignancies, sir.
So what are other associated diseases?
Sir, with the dermatomyositis, systemic sclerosis, pernicious anemia, hypothyroidism, autoimmune associate, they are all autoimmune associations, sir. Diabetic myasthenia gravis, sir.
Very good. So you said about different types, they're all correct. What's amyopathic dermatomyositis?
Sir, amyopathic dermatomyositis is associated with an antibody MDA5, sir. It predominantly involves the lung, sir. In a dermatomyositis involving the interstitial lung disease, muscles are not very much affected and also has calcinosis cutis as one of the symptoms, sir.
So amyopathic dermatomyositis situation where you get skin manifestations,
yes, sir,
and absence of muscle manifestation.
Yes, sir.
So that is a peculiarity of amyopathic dermatomyositis. Looks like dermatomyositis by apparently looking at the skin, but the enzymes will be normal and there is no muscle weakness.
Yes, sir.
So, myositis is basically immune-mediated muscle inflammation, and muscle affected is usually, as you said, proximal muscles. Why do you get dysphagia?
Sir, dysphagia in dermatomyositis can be due to the fibrosis, sir, muscle fibrosis post myositis. During that time, we get dysphagia, sir.
No, during the acute episode, why do they get dysphagia?
Myoedema, sir. During acute episode, there is a myoedema.
During the acute phase, these people have got involvement of the upper pharyngeal muscles.
Yes, sir.
So, anatomically, the history will be suggestive of pharyngeal type of dysphagia. How do you differentiate pharyngeal dysphagia from oral dysphagia? If you have got paralysis of your tongue, you are unable to swallow, how do you differentiate it from pharyngeal dysphagia?
Sir, in case of pharyngeal dysphagia, the difficulty will be more for solids, sir.
And in oral dysphagia, the patient's food will stick in the mouth only.
Yes,
it will not go to the throat.
Yes, sir.
So patient will pushing the food to the throat in case of oral dysphagia. Pharyngeal dysphagia, that part is clear. And the patient will point to the throat where it is sticking.
Yes, sir.
So the patient will be, if you analyze the history properly, you may get signs. Okay, so you said about dermatomyositis. Tell me some pathognomonic signs of dermatomyositis. Two are there, two pathognomonic signs.
Sir, shawl sign, photosensitive rashes, Gottran's papule, heliotropic rash, Gottran's papules, sir.
There are a lot of signs. Which are the two pathognomonic signs?
Sir, Gottran's papules, sir.
Gottran's papule is correct answer. One more.
And mechanic hands, sir.
No. Heliotropic rash.
Heliotropic rash, yes, sir.
So what is Gottran's papules?
Sir, there are small papules present on the knuckles of the palm, sir.
No, palm, no hands. Okay.
Huh.
Over the metacarpophalangeal joints and intraphalangeal joints.
Yes, sir.
And in between the proximal and distal intraphalangeal joints.
Yes, sir.
So it is a scaly one. So what will be differential diagnosis?
A wart can be a differential diagnosis, sir.
Scaly lesion, commonly we think about psoriasis, no? Psoriasis,
yes,
and lichen planus will be too close. Differential diagnosis. So what difference between Gottran's patch, papule and Gottran's sign?
Gottran's sign is
just erythema over the dorsum of the fingers. That's called as Gottran's sign. Okay.
Yes.
And tell me about heliotropic rash.
Heliotropic rash is present over the eyelids, sir.
Around the eye, okay.
Eye.
What is the color?
Sir, it's a purplish violaceous rash.
Yes, okay. What other signs you said the calcinosis cutis.
Yes,
are there any other condition where there is calcinosis cutis other than this?
Sir, in crust syndrome, sir, in systemic sclerosis.
Very crust syndrome, overlap syndrome, dermatomyositis, yes. Very good.
Yes.
There are a couple of other conditions where you can have other signs of dermatomyositis. They can have generalized facial erythema.
Yes, sir.
Facial erythema. Here, unlike the SLE rash, nasolabial fold will not be spared. And they will have called as poikiloderma.
Yes, sir.
What is poikiloderma?
Sir, in cold temperatures, they will have a development of rashes, sir.
No, it is both a combination of hyperpigmentation, hypopigmentation, simultaneously in between telangiectasias also.
Yes, sir.
So, usually seen in photosensitive areas, and when occur in the shawl area, you got say shawl sign. When it occur in the front of the neck, you call it as V sign. Yes. So, what is holster sign?
Holster.
It can occur on the lateral side of the thigh. Same thing. When you call it as
holster signs.
And what are signs is nail, the fingertips?
Sir, nail pitting of nails, onycholysis can be there, sir.
If you look at the nail capillaries, what you find?
Nail capillary folders are burnout, sir. Burnt out capillaries will be seen, sir. Nail capillaries.
Alternate areas of dilatation and alternate areas of dropout. And you
Yes,
may
sir.
find erythema around the nails, periangular erythema, and there may be cuticular hyperplasia. Okay, sometimes you may see psoriatic-like lesions, and sometimes you may find erythroderma, generalized erythroderma.
Yes, sir.
So, other signs of the skin you already mentioned. Yes. So what investigations you plan in this particular patient?
Sir, we have to do a muscle biopsy, sir.
No. Go to non-invasive things first. You
Sir,
are right.
CBC, a complete blood count, sir.
Okay, here normocytic normochromic anemia.
Yes, sir. Then renal function test, sir.
Then normal.
Liver function test, sir.
Okay, why do you have this priority of renal function, liver function, and CBC? Why this preference?
Sir, renal function test, dermatomyositis can, if it's a connective tissue disorder like systemic sclerosis, scleroderma, it can affect the kidneys, sir. Scleroderma, renal crisis. So we need to know what is the creatinine level, sir. That's why RFT, sir.
No, your what is the basic diagnosis in this case? According to you to plan the investigation. CBC
Sir,
is
dermatomyositis, sir.
So what's the investigation you want? In that we'll go one by one. Okay, what investigation you want?
Sir, ANA, sir, anti-nuclear antibody, sir.
So what is the myositis means inflammation of muscle. What's the clue? The muscle is inflamed.
Sir, CPK, sir.
That's right, muscle enzyme. It was very high. What are the 5 muscle enzymes you know of?
Sir, CPK, LDH, lactate dehydrogenase, aldolase, then
AST and ALT.
AST.
Commonly we do the CPK. CPK was very high, and you want to do an ANA. That's done. It's positive. What else you want?
Sir, how to do a line immunoassay, sir, LIA23, sir, to see which antibody is involved after ANA.
So this is the pattern we have got here.
RNP SM is positive, anti-DS DNA positive, SM is positive, RO52 is positive, sir.
So how do you go further?
Sir, RNP SM is positive in case of mixed connective tissue disorder, dsDNA SLE, SM smooth muscle antibody, Smith antibody.
I would have written the small letter M. Okay, that's why you got mistaken. Smith antibody.
And RO52 is also positive, sir.
So what do you make out?
Sir, it's more in favor of a systemic lupus erythematosus, sir.
So how do you explain the high CPK and LDH?
Myositis can rarely be present in SLE, sir.
How do you explain the tightness of the skin?
Sir, then it should be a SLE MCTD overlap, sir.
You say MCTD only when all other antibodies are absent, and only you have got Raynaud's phenomenon, pulmonary hypertension, all those things, but not proximal muscle weakness and so on. Other antibodies should not be present in case of MCTD.
Okay,
MCTD,
sir.
when you follow up, sometimes they go into some other disease, and MCTD may be only the beginning.
MCTD can evolve into SLE, sir.
Okay, that's right. So, what is the possible diagnosis here?
MCTD evolving into SLE, sir.
So, how often you make a diagnosis of rheumatic diseases when the patient comes to you? It's a specific diagnosis.
Sir, a specific diagnosis can be rare because of overlap, sir.
That's right. So, 25% of all patients remain elusive. You cannot put them into any definite pattern. So previously, everybody used to be called as collagen disease. Subsequently, people started saying that it's a connective tissue disease. Then it became undifferentiated connective tissue disease. Okay. So currently, the term is systemic rheumatic disease, better
Yes.
term, where
Yes.
you find that two or more specific features are overlapping. For example, this patient, specific feature of myositis, specific feature of Raynaud phenomenon with the thickening of the skin, and
Yes,
the
sir.
bodies are pointing to SLE. So you have features of specific pattern of different diseases. At the same time, you cannot make a diagnosis
Yes, sir.
because everything has got overlap. So early Raynaud's phenomenon is always a problem. You cannot make a diagnosis. Sometimes arthritis also creates a lot of problems like this. Skin rashes can also have problems. So muscle disease also have problems. So multiple symptoms and signs can always overlap in these cases, and you don't put a diagnosis in them, because once you put a diagnosis in them, it goes without saying this is the prognosis, this is the treatment,
Yes, sir.
the outcome. In this group of patients, you will not be able to say definitely the outcome, definitely the course of the disease, definitely the prognosis. You cannot predict. It's always better to don't stamp them as any group. You put them undifferentiated systemic rheumatic disease.
Yes, sir.
So, you see that Raynaud's phenomenon, that symptom is shared by many diseases. MCTD can have Raynaud's phenomenon. Systemic sclerosis can have Raynaud's phenomenon. Sjogren's has Raynaud's phenomenon. SLE can have. So it goes with everything. Arthralgia with the morning stiffness can go with all diseases. Again, you cannot make a diagnosis.
Yes, sir.
Now, muscle disease can also have different pattern. So the symptoms are shared by many diseases. Looking at the investigation reports, these investigation reports, ANA can be shared. So these investigation reports can also be shared by different entities. So it's very difficult to come to a conclusion what it is. So how to treat this patient?
Sir, steroids, sir.
Okay, before we go for that, I forgot muscle biopsy may not always clinch the diagnosis unless because all the muscle parts are not affected. It's a patchy involvement.
Yes,
So
sir.
sometimes you may miss the diagnosis, and it's invasive procedure. Myopathy pattern of EMG will be helpful to indirect clue the muscle is affected.
Yes, sir.
Okay, so we start with the steroids, anti-inflammatory dose, and then you can bring down the dose and go for steroid sparing agents.
Immunosuppressants like azothioprine, sir.
That's right. So that may be tried. So here we have some features of all these conditions. So you can put this condition as undifferentiated systemic rheumatic diseases. And when you follow up, evolution of the disease will take place over a period of 5 to 10 years. And you will find 30% of them definitely will evolve into a specific diagnosis over a period of time.
Yes, sir.
So that's evolution. Now what about resolution? Resolution is very, very, very rare. It is seen less often. Okay.
Okay, sir.
So some of them may remain as such, and you will not be able to reach anywhere. And MCTD is different from our lab. What's MCTD?
Mixed connective tissue disorder, sir.
Yes. So specific disease where you don't have any other antibody, but only the RNPS1.
Yes, sir.
Okay. So when there's a combination of rheumatoid arthritis with SLE, what do you call it?
Rufus, sir.
Lupus. Similarly, when there is combination of scleroderma with polymyositis, what do you call it?
Scleromyositis. Sclerodema.
No, not scleroderma. Not scleroderma.
Scleromyositis.
Scleromyositis. What is scleroderma? Scleroderma is a benign condition seen in obese people and diabetic patients, where you find that there is induration and swelling occurring in the back of the neck,
Yes,
and
sir.
back of the chest, extending on up the hip. Sometimes precipitated by some infections, and the benign process does not require investigation treatment. After a course of time, it may disappear by itself. So
Yes, sir.
you may find that there are different types of overlap. In this particular patient, This is the way it evolved, and we have started the treatment, and patient is doing well.
Yes, sir.
Do you have any doubt, Vignesh?
Sir, irrespective of the diagnosis, no, sir, it has features of polymyositis, systemic sclerosis, and SLE, sir. Can we start steroids because steroids may worsen systemic sclerosis, sir?
No. This is not absolute systemic sclerosis. Here, the
Yes.
dominant complaint of the patient is muscle weakness.
Yes, sir.
So, accordingly, you can treat. And
Yes, sir.
if it is systemic sclerosis alone, the features will be entirely different.
Yes, sir.
That is not happening here.
Yes,
Some
sir.
features are there, some features, but not all features. Dominant
Yes.
one here is a proximal muscle weakness. Patient cannot get up, cannot roll in the bed. So complaints are mainly neurological rather than others.
Yes, sir.
Okay. So any other? As you rightly said, steroids are no good in case of systemic sclerosis. It can produce flare-up.
Yes, sir.
Okay. Anything else? It's a good presentation, Vignesh. Thank you.
Thank you, sir.